So, you should be able to see, if you those of you who have the goggles on, Tamika's going to move the couch so that it sticks out and it's going to really appear like it's sticking right out of the machine. So you can see the 3D effect, so that we've got that. The reason why we have the theater ropes in front of the screen is because when you have these 3D goggles on and you're working the machine, your mind really gets involved in this, and you forget that you're in a classroom and not in this environment, and you can fall into the screen. And MD Anderson thought that it would be a little costly if we had to keep replacing the screen. And so we actually even have a buzzer over there that if you get too close to the screen, it's going to give you a warning to get away from the screen.
I want this too.
It's wired into that. Okay, so now Tamika's going to show you
We could totally use this for RT. Especially even for like CAT scanning MR.
Okay, so generally when I would use it for anatomy class, a lot of times I will refer to not just the structures in the body and where they're located, as far as where your trachea is located in comparison to where your esophagus is. You can see there, you can see the spinal cord there going right through the vertebral foramina. You can see your esophagus line here and your trachea in relation to there. And then I kind of use that as a tool to show students on a CT also what different structures are and where they kind of lie on that structure. And I can make my patient as transparent as I want to, or I can really get close up like I'm peering inside of the patient's body there and kind of adjust these things here. And let me take off this. Oh, okay, sorry. Okay, take this off. We can show the anatomy, how the anatomy lies in the body. Sometimes I've noticed with students, I allow them to kind of tell me what they see, because a lot of times they have very misconceptions about where everything kind of lies in the body. Some people think their liver is lower than what it is. They think other structures are higher than what it is. And when they're treating patients, they really don't have a good concept of where their anatomy kind of lies inside of the patient. We talk about that and go over different landmarks, where your landmarks in the body are in accordance to where your spine kind of lies there. I can also turn on, let me go ahead and turn on coronal, sagittal, let's turn all that on, and I can actually turn the patient this way, and we can see the patient here from a coronal view, what I'm kind of looking at. Okay. What is oh. You can kind of see where we are in the patient and what it looks like, where our lungs are and things like that. I can also turn on all the different structures here for the patient, where their left lung is in relation to the right lung, in relation to where this particular patient's tumor is. And these are all real patients that are loaded into the system, and you can see this big tumor kind of wrapping around very critical structures and organs at risk. So it's really wrapped around, looks like the trachea, the esophagus, coming pretty close there to the spinal cord area, and those are things that we have to kind of be aware of when treating the patient and what their tolerances are to these different structures inside of the body.
The important thing that you really need to remember is, as you're looking at this graphical representation is of a real patient. So the CT data sets were of a real patient. All of the data that was collected on the patient was fed into the computer, and it created the virtual patient on the table. So one of the things that we do in our radiation therapy program now is when our students go do a competency in the clinic, if they fail that competency, they must get the data from that patient, we feed it into the virtual, and they must come in and treat with the faculty members on the virtual system until they treat the patient correctly before they go back in and try to demonstrate competency again. So it's really a phenomenal system.
And on the treatment machine, this is generally a view that we see. We're kind of looking at the MLCs while we're treating our patients. So another concept that we want them to get used to is when they're on the treatment machine, kind of looking at these different shapes, making sure these different shapes are correct with the correct gastric angles that the patient is having. So I think it's all, with our students, a lot of getting used to looking at things that the therapists are looking at.
So what you're seeing now is the actual treatment of the patient. All the individual radiation fields that are being delivered. You see the blue and the green lines that are coming in on the right-hand side? Those are called multi-leaf collimators. So they're helping to define where the radiation is going to go. The blue and the green are blocking the radiation out. So we're trying to conform the radiation to this person's tumor. The interesting thing that for you guys to know is, many of you may have heard in the news about a year ago, some patients in New York were actually killed because of overexposure to radiation during their radiation treatment. The errors were simply related to the fact that those multi-leaf collimators were not working. They were not turned on. So instead of shielding parts of the patient, the entire field got irradiated, and it was enough to kill 2 patients.
Jesus.
Okay? The great thing about this system is, what the radiation therapists see, and there's plenty in the room, you can correct me if I'm wrong, when you see that graphical representation of those leaves sliding open and closed, that's exactly what the therapists see in the clinic. So it is a real true-to-life simulation.
And that's just showing all the beams that this particular patient has that's working on. Turn that all off, and here I want to kind of show
Not me, buddy.
While Kamika's doing that, let me tell you another thing that I think that the radiographers in the room will really like this.
I can see it in 3D on my computer.
It's called image-guided radiation therapy. And what we will do is we will take images, radiographic images, before the patient is treated. We set the patient up, we get them exactly where we think they should be, then we take a couple of radiographs. Well, then what we can do is we can superimpose the digital radiographs that we just created over the radiographs that were done the first day when the patient was simulated. And we can then line the 2 images up on top of each other. Okay? And then we can tell the machine to now line the patient up that way. So instead of just lining up to the patient with marks on the outside of the body, we can now take the bony anatomy, we can take the markers inside the anatomy, superimpose them on top of each other, and be assured that we are treating exactly where we want to treat. Then we can hit a button, and the machine will move, and it will superimpose the patient over to that image, and it lines them up directly internally instead of just externally. And we actually have that capability of doing it here on this system, but you have to do it on this little screen, and you guys probably know.
this was not done it, but what we're able to do also is turn on what we call dose clouds for each patient in each tumor area, and really see how much area is receiving how much dose around the area. This is our color gradient on the side. It's going to tell us in the centigrade how much dose our patient is actually getting to different structures inside of the body.
So what you're seeing here is, if you see the pink box right here, The pink box is saying that the area is getting 1,014 centigrade, okay, or rad. So wherever the pink is, you know that 1,000 centigrade is going there. So we can see truly where the radiation is going. We can see it on the organs, which is, of course, something we can't do in the clinic on the patient.
That's the tumor area, and that's the lobe around it, and it's showing 4191 centigrade that our patients are getting here.
Why don't you bring up the rapid on plastic and show them the treatment, the actual treatment. The next thing we're going to show you is a newer technology that we've started to use here at MD Anderson. It's called Rapid Art. And what happens is the machine is going to move around the patient. Remember when you guys used to do tomos for kidneys and stuff like that? It's like a tomo. The machine's going to move around the patient. For every degree the machine moves, those collimators are going to change their shape because they're going to block out the radiation to the normal tissue around the tumor from that angle. And it's going to travel for several degrees around the patient. The other thing that can happen is during this, the actual radiation energy can change. So what you're seeing here is the machine is moving around, it's highly choreographed, the patient's being treated. This is a prostate treatment if you didn't already figure that out. And so we can see what's happening to the outside of the patient, but the amazing thing is, Tamika will zoom right into the patient and we can see what's going on inside the patient. And there's the prostate, there's the tumor being treated. We can turn on all the anatomy, we can take a look at the rectum, we can take a look at the bladder, we can take a look at the humeral head, we can see what's going on, what's being treated, what's not being treated. And what we can do is, you can see that this is a real-life simulated environment because as we get closer inside the patient, the volume goes up. It's probably the one thing I don't like about the system, but it is real life. The closer we get to the machine, the louder it will be. So now we can see the structures that are being irradiated. What we can do in a safe environment is actually the students will say, well, come on, really, what matter does it mean if you're 2 millimeters off? Well, let's go 2 millimeters off and let's take a look at exactly what's happening to the rectum and the bladder and what part of the tumor is not being treated because we're 2 millimeters off.
Okay, which direction you want?
So that the students can see that firsthand.
Okay, let's go.
Yeah, look like they're too
So
low.
create some error, set of error, in here. And,
While she's creating the set of errors, this is probably one of the biggest flaws to the system is when the therapists are working with the patient, they have to physically touch the patient and move the patient. Where because these patients are in a virtual environment and we don't have gloves and all that kind of stuff, we can't do that. So but we can do is we can rotate the patient, we can change the pitch of the patient, but we do it electronically on the scale. And,
Okay.
and then the students have to move them that way.
The red is going to be your prostate. Here you have your bladder and your rectum, and we're always stressing the importance of why our patients have to have a consistently full bladder. It does two things. It's going to stabilize that prostate, and it's also going to kind of move small bowel that we don't want in the treatment field out of the treatment field, and it also will push some of that bladder outside of the treatment field that we are going to be treating. So we can really stress the importance of that. The doctors aren't doing it just to be mean to the therapists and get on their nerves every day because of the water drinking patients, clients. It's really because that we're trying to avoid certain structures in patients. So let me get this going and we can kind of play the animation. And when you create errors, you can kind of see that the prostate is not going to get the same coverage that it would if it was right on. So the more I create certain errors in the patient, you can kind of, with an adjustment, my coverage is going to be a little bit different on the patient, and I'm really not going to be treating all of the prostate.
And you can see the portion of the prostate that now is not getting treated.
This bottom part is probably not getting the dose that it should. I'm creating cold spots where it shouldn't be cold spots. I'm creating hot spots where there should be hot spots. I'm creating more of that rectum area will ask, well, you know, what really is the big deal about doing these things? Well, if I over-irradiate the bladder, it won't function properly. Anything that I irradiate past its tolerance dose is not going to function the way that it should function, meaning that patient is probably going to have some type of incontinence going on. The bladder's not going to stretch like it needs to stretch every day for that particular patient, and I've given them a long-term disability, basically, from radiation that's actually supposed to help them. So I've kind of defeated the purpose of what I'm doing. I'm trying to create a quality of care for my patients, not just treat them and get rid of their tumor, but give them quality of life as well. Another problem is if I over-irradiate their rectum, same thing. I'm going to cause them more reactions than they actually need to have. And that's kind of the thing that we're always combating with radiation therapy. We're trying to find that balance to eradicate the tumor, but spare normal tissue. And that's what I want to do with every patient. No matter if I'm treating them for a palliative case, meaning I'm just treating them for their pain, or if I'm treating them for cure, it doesn't matter. I should be treating a patient to the best of my ability every time and try to be as accurate as possible for every patient.